remember that patient who had such an emotional impact on the team because things didn't go well. How are we going to keep that from happening again? And that's one of the things that I really try to draw out with team members when I'm designing a simulation or a simulation program to address ECMO, is connect it back to something that is emotional and meaningful for the team, because a checkbox is not.
Welcome to the Dare to Be Ready podcast. This is Chris Rusin from the Center for Medical Simulation and the CMS ALPS team. I'm here with my co-producer and co-host, James Lipshaw. James, how are you?
I'm doing great, Chris. How are you doing?
I'm doing well. Previously, in our earlier episodes, we really did the process of readiness planning real time. And in today's episode, we'll actually be presenting the point of view of someone who is a clinical program leader. And so we'll be showing you the perspective of that kind of person who's deeply practiced in the art of readiness. An incredible guest today, Catherine Allan from the Cleveland Clinic. Catherine, how are you?
I'm doing great, Chris. It's so nice to talk with you today.
It's so great that you're here. Catherine, one of the first things I do when I introduce our guests is, I just say their name. So Dr. Catherine Allan from the Cleveland Clinic, and also say their title. And you have a lot of titles, as a lot of people sometimes do in healthcare. What happened there? How'd you get so many titles?
I just say yes to a lot of things. I guess that I just am passionate about many areas of medicine and very passionate about quality and safety and using really unique tools to support quality and safety. And those tools include simulation. So that gives me clinical roles, clinical leadership roles, and roles with our simulation program, and then roles with our quality and safety team. So I say yes where my passion takes me, I guess.
Okay, well, that's pretty cool. I'm going to read off some of these things, Catherine. So you are Director, Cardiac Care Unit and Inpatient Cardiology. You are Section Head, Cardiac Intensive Care. You work at the Children's Institute, Department of Health, Vascular and Thoracic, Division of Cardiology and Cardiovascular Medicine. You are the Robert J. and Suzanne M. Tomsic Endowed Chair and Core Faculty in Human Factors and Systems Design, Simulation and Advanced Skills Center, and also an officer for Human Factors and Systems Design, Safety, Quality, and Patient Experience, Children's Institute at the Cleveland Clinic. I may have said some of that with the wrong emphasis, but did it sound about right?
Yes. I wear a lot of different hats, but they're all interrelated. So
yeah. Catherine and I used to work together at Boston Children's Hospital, and I'm just delighted that Catherine's here because she's one of those people that beautifully combines being a very serious person who's exceptionally good at what she does and also delightful to be around and to work with. So welcome, Catherine.
Oh, Chris, thanks so much for that very kind introduction. And it's really fun to be able to work with you again today.
James, as always, please jump in. Catherine and I love to talk to each other, so we could get going. Any kind of powerful points that you always make, please do. In every episode, we talk about some specific readiness challenge. And I'm excited today because you are going to be talking about a readiness challenge that actually you and I have worked on together in the past, and that's very core to your career and that you continue to work on, and I only sometimes get to think about and work on these days. So I would love it if you would describe for us right now what the readiness focus is today.
Yeah, thanks. So today I wanted to talk about readiness for pediatric extracorporeal membrane oxygenation, or what we call ECMO for short. So ECMO is a technology and a care process that allows us to support the function of the heart and the lungs of children of all ages and sizes who are experiencing life-threatening illness. So when explaining ECMO to family members, I often describe it as being similar to a heart-lung bypass machine, and with the difference that we can maintain patients on it for days or sometimes even weeks to provide life-saving care, either as a bridge to a definitive procedure or as we will often say a bridge to recovery to allow their body to heal and allow us to provide treatments while their body is healing. So it's a really, really complicated therapy, and it's a very high risk therapy and one that we would say is an infrequent therapy. So while in an ICU setting, for example, just to set the stage, we have patients on ventilators every day helping to support breathing. We might only have patients on ECMO a third of the days, or sometimes even less, depending on the size of the ICU that you work in. And so our teams need to be prepared to deliver this high risk therapy infrequently. And so that makes it an even greater readiness challenge.
Okay. Thank you for that. And Catherine, a couple points of clarification here. So
Mhm.
sometimes I hear the term ECPR
Yeah.
and we hear the term ECMO. Are those the same thing and how do those overlap?
Oh, that's a great question. So ECMO is the technology that allows us to support the patient, and we can deploy that technology or use that technology in a number of different situations. ECPR means providing ECMO therapy to patients who are actively undergoing CPR. So, to describe that a little bit more fully, that means the patient is in the midst of a cardiac arrest. The team is providing standard cardiopulmonary resuscitation. That means chest compressions, ventilation, medications, and decide that they want to put the patient on ECMO, which is a invasive surgical procedure, and they do that during CPR. So when I think about preparedness, there are teams who need to be prepared to use ECMO during non-CPR situations, but it's even more extreme, if you will, to use ECMO when a patient is undergoing CPR because there's even more of a time pressure and more of an urgency in that setting. Because the longer CPR is ongoing without the provision of ECMO, the lower the chances of survival for that child and the greater the chances of significant neurologic injury. And our goal in any area of medicine, but especially in pediatrics, is never just survival, but actually going home from the hospital and being able to function and for children to grow and develop and meet developmental milestones. So it's never just about the can we, it's about the how can we.
Well, even activating and initiating ECMO and kind of making it happen was very complex. Maybe you can tell our listeners how big is the ECMO team when you activate and then they have to make it happen? Like how many people are involved?
A lot. And I think one way to think about it and describe it is using language that you yourself have coined, which is the concept of microteams. So in the ICU, when we're running a standard resuscitation of a patient who's not going to get ECPR, then you have the ICU team, which might be 5 or 6 nurses, 1 or 2 doctors, a nurse practitioner, a respiratory therapist, maybe a pharmacist. But when we're doing ECPR, we have that micro team, and then we have 2 additional micro teams. One of them is the surgical team, which is made up of a surgeon, usually an assistant, who's standing across the table from them, and then surgical nurses who are responsible for handing off instruments, making sure that all of the surgical supplies are ready. So that's another micro team. And then the third micro team is the ECMO team or the perfusion team. So they're responsible for preparing the ECMO circuit or machine. So they're in charge of the technology, making sure that we have the right interfaces between the patient and the machine. Those are called cannulas. They go into blood vessels or directly into the heart. And they have a specific expertise in running that machine. So we have those 3 separate micro teams. And so you might have 20 people in the room when you are conducting ECPR to save a patient's life. And those teams not only have to work really well in their own individual teams, but they have to work well together across their teams because everything that we're doing is orchestrated carefully across the three teams. You can't do it in isolation.
Yeah, and wow, incredible precision skills on the surgical side I learned over time. Some surgeons are really great at this, and some of the patients for ECMO are quite little in your world, right?
Right. Yeah. So that's one of the challenges, I think, for pediatric ECMO in particular, is that our patients might range in size from about 2 kilograms up until, a full-sized adult. And so we have to, and they might have different strategies and different challenges for cannulation at each of those sizes. So we have to be prepared from a technical skills perspective, our surgeons in particular, to meet all of those challenges. Um, so that's one of the biggest differentiators in between pediatric ECMO and adult ECMO.
I mean, you work at what's often described as the very best hospital in the country and in the world at the Cleveland Clinic and have very high standards, of course. And I would hope we have high standards across healthcare, but there's all kinds of potential for things to go wrong that we live with every day in healthcare. It's really hard to find training time and make training happen for complex things, but ECMO is complex. How do you make training time happen for ECMO?
When you and I worked together at Boston Children's Hospital, we had a team that had been delivering ECMO since the 1990s and doing
Yeah.
ECPR for much of that time. And they had great skills and clinical expertise and know-how, but recognized that they recognized themselves that their fundamental gap was around teamwork and communication. So I think the first thing is understanding what it is people feel they need out of training. And that you and I, as people who've deployed a lot of ECMO training, may think we have a prepackaged, product that we can just pick up and take wherever we go. But the reality is that I think to get the time for training, you need to meet people where they are and solve the problem that they think is their problem. So I'll give another example of that. I'm currently at my current institution. We do, I would say, moderate amount of ECMO, and the team is skilled. But we recognized when we had a really difficult ECMO case about a year ago. And fortunately, the patient did great and walked out of the hospital and is thriving. But we recognized that for us, what we had was gaps in our systems and processes. And so it became very easy for me to start working ECMO simulation into the mix when it was addressing the problem that we had, rather than saying to the people, oh, we should do teamwork training for ECMO. They didn't perceive that as the problem. Now, I will tell you that when we did our clinical systems tests using simulation, we did recognize that teamwork was part of the problem, but we went in addressing the problem that the team thought that they had.
Anybody doing something complex, team-based in healthcare, or really across any industry, um, one of the points that Catherine just highlighted is you can't just show up with heroic training and expect people to be grateful for it. You need to be connecting with people and understanding what they perceive as their challenges, what they perceive as their role in solving their challenges, maybe ultimately designing training, but you don't jump to that upon arriving in the room with people, and you certainly don't show up with a prepackaged solution unless you want to be rejected. So I like to use the phrase, Catherine, you may remember me saying this one around the house at Boston Children's, psychological ownership. If people don't own the need for training, if people don't own the design of a solution to a problem that they perceive that they're having or that the team's having, then it's really a non-starter. You're not going to make much progress, or the whole thing's going to feel like a compliance exercise that the team is
Yeah.
resisting.
Can I
And
digress for a moment?
yeah, please, of
Please.
course.
That statement just resonates with me so much because one of the things about my current job, so I work at Cleveland Clinic, which is known for its approach to quality and safety.
Hmm.
And they have a very rigorous continuous improvement methodology that's deployed across the institution using standardized methodology. And I've learned so much from it. And it often boils down to objectives and key results. So we might have an objective like reduce serious safety events, and then we have key results that contribute to that objective. And those key results are met with interventions that often look like things like checklists, or, there are things that we have to operationalize at the front line.
Yep.
And as a leader, one of the most important things I can do is help to translate for the team, why is this intervention of, and I'll bring it back to ECMO, doing an 8:45 p.m. ECMO huddle for our high risk patients. How is this actually connected to our serious safety event rate, if that's our objective?
Mhm.
Or how is a checklist about central line utilization that we do every day connected to reducing risk for our patients? Um, and so I'm diverting from ECMO, I guess, a little bit, but I think that when we think about quality and safety, it's very easy for the front line to become disconnected from what are we trying to achieve. And as people who develop curriculum or develop safety simulations, I think our imperative is just what you said. We need to have that connection to the things that are meaningful for the team. So if I can bring it back to, remember that patient who had such an emotional impact on the team because things didn't go well, how are we going to keep that from happening again? And that's one of the things that I really try to draw out with team members when I'm designing a simulation or a simulation program to address ECMO, is connect it back to something that is emotional and meaningful for the team, because a checkbox is not. So
Right.
that's actually the beauty of simulation, is that we have the power to create an exercise that also really fills an emotional need of the team,
Yeah,
helps the team build resilience in the face of a job that is very difficult to do, in a
definitely.
way that some quality and safety approaches cannot.
One of the things that we used to lead with at Boston Children's was being able to tell people that they themselves or their colleagues had designed the training. And if you can say that at the beginning of a training, wow, the credibility, the acceptance, the willingness to engage. And of course, that requires you to design the training a particular way. You do need to engage with those groups, and you do need to involve all of the different types of professions that are involved in the work and build something that is wanted, well designed, likely sustainable, and so on and so forth. We're always, anytime you try to introduce a learning based or a training based solution to a problem, you are always wrestling with the history of those solutions in the institution, in the organization, in the unit. And the history of training, attempts at training, even something as noble as simulation, the history of those things is sometimes off the mark, and so consistently off the mark that people don't trust training. They don't think it's useful. Why? Because they have lots of empirical evidence that it's not. And oftentimes people who are good at designing simulation, they walk into a room and they say, why wouldn't you want this? It's the world's greatest thing. And at that point, we're actually, if you're the simulation person or the learning person, you're actually not empathizing well with your
Mm.
audience, which is people that have been through so many trainings that weren't helpful for them.
I remember my dear friend and former colleague Tony Impresia, who runs the um, orientation program for the pediatric cardiac ICU at Boston Children's for
Mm,
nurses.
love
Used to
Tony.
talk about, so they had a very simulation heavy orientation program. And I
Yeah.
remember her talking about the challenges in the early simulations for her, because many people came out of nursing school having
Right.
experienced simulation as either a way that they were tested, or just not an optimal learning environment, and had it, she had to overcome that in her approach to her simulation based curriculum, to allow people to experience it in the way that she thought would, hoped would be most valuable to them. So people carry baggage about simulation,
Yeah.
and it's important for us to acknowledge that.
How did you get to that? And what do you recommend to people as they're trying to do a readiness plan themselves?
Yeah, I think for a really complicated, I don't even want to call it a task, because it's so much more than a task. It's for a really complicated procedure or process. I think for me, the way I approach it is the first thing is I need to understand the process myself. So for ECMO, I have the advantage that I'm also a clinician who takes care of patients on ECMO and participates in an ECPR team. But if I'm going in to work with a team where I don't understand the work that they do, the first thing I need is to really understand the steps. So I like to use process maps to understand what things need to look like, and embedded within those process maps, I will like the swim lane approach because it also breaks it down into individual roles. And then within each of those process pieces, you can pull out the tasks. I guess I am naturally someone who starts to categorize things. So there are roles and responsibilities, there are tasks, there's equipment, and then there are systems or process pieces. So you talked about the fact that we actually need to activate ECMO. So we need to figure out how to get the whole team there in an emergency. And so that might be the processor or organizational piece. You really have to have a deep understanding and gain a deep understanding from the people that you are working with on the clinical side of exactly what this task or this process or this thing is that they are seeking training around.
Some of the basic recommendations that we make to people when they're building a readiness plan, even a very simple one, is to come together with the right people who probably know the process and talk it through, which is going to require taking a little time and having some organization to your conversation, but talk it through and say, what are the pieces here? What are the things that we do when we resuscitate a patient? What are the things that we do when we activate ECMO?
Can I ask you a question, Chris? Because one of the things this brings up for me is, often when we have a team that comes to us because they have a training need, or they have a simulation-based testing need, they come to me and they say, I want to run a scenario. I want to run a simulation scenario of a patient in cardiac arrest. That's the most common approach, probably. Whereas it's very difficult to understand exactly what you're trying to help them with if that's all they say is, I'm coming with you because I want to run a simulation of a CPR event in the emergency room.
Yeah.
And it often requires actually a lot of convincing to help people understand that just handing them a scenario and helping them run a simulation is not actually going to achieve their goals. How do you think about approaching the person who's coming to you who thinks that this is going to be, we're just going to run a simulation? How do you help bring them to understand that if we don't have a deep shared understanding of the problem we're trying to solve, we're not going to give you a good product?
It's very unsuccessful in healthcare to say, let's really slow this down. Then people just ignore you, walk around you, and go get it done, right? So you can't totally slow it down.
Yeah.
But just briefly pausing and saying, okay, what I can help you do in this moment is optimize it. And the way that we optimize it is we think about what are some things that have recently happened related to this type of scenario or activity. What are the gaps involved? And don't worry, we won't take too long on this.
Yeah.
But let's sit down and think about it together. Let's get some recent organizational history. Let's try to get some data involved. Let's get multiple voices involved. And let's make sure that we design ultimately the right learning scenario or practice scenario, rehearsal or testing, whatever it ends up being. But if we can just slow it down, or the word slow it down, really, as you know, doesn't go well in healthcare. You don't like that term, right, Catherine? You're like, Chris, you're slowing me down today. Why are you doing that? So we just want to take an intelligent pause that actually will ultimately speed us up and get the right people in the room, have that conversation about gaps, have that conversation about the situation. And we know, Catherine, you and I know from many, many reps, you will not end up with the scenario that they originally intended on running. You'll end up with something a bit different, or maybe very different. You might end up with a skills workshop instead of a free-flowing scenario. You might end up with some skills practice and then a scenario that builds off of that.
Well, thanks for that advice. And I really like that word that you used, optimize. I think that's really good language to bring to the conversation because it acknowledges that they've already put a lot of forethought into this and they do understand their problem.
Yeah, and we hate, and you don't want to inadvertently insult the person who has enthusiasm to create a training.
Yeah.
Right? that's always one of the tensions and one of the balances is how can I respect this person? How can I welcome them? How can I help them by optimizing, by improving? And we've seen it many times over. When you do that well, people are really blown away. And what you're creating is something that's totally sustainable. And we've seen programs live for 5 years and beyond, that were originally intended to be just a quick one-time thing for one reason or another. And that's the best feeling, that you're creating something that's truly helpful, that people want, that they're actually demanding over and over again. And you usually get that by optimizing on the front end.
I think the principles that I've learned in other training venues are really important to bring to this conversation. So, in general, sort of leadership training really today teaches you the importance of the voice of everybody on the team. And I had the opportunity to take a design thinking course several years ago at Stanford, which really also emphasized the fact that you really need to engage the voice. They would talk about the voice of the customer, right?
Yeah.
Those are the people who need to be involved in the design process. But it's important to think about other ways that those principles are supported. Because it's really not just our simulation methodology, our simulation educational methodology that tells us that. They're really important principles to hone for us in all aspects of our jobs.
James, I think we're going to make that our call to action today for today's conversation, which is remember to have that expertise and listening balance dialed in when you're trying to create solutions, learning-based solutions, whether they're simulation-based or process design-based or otherwise. Having listening engineered into your process as a creator and as a team builder is really, really essential to getting it right and to creating something that's sustainable and truly does optimize in the moment. Because even if we're well intended, if we're at any level forcing solutions on people or trying to shortcut it too much, then it can be a real problem for what comes out. I want to thank Dr. Catherine Allan. What a pleasure. Catherine, we do want to invite you back. We're going to let you rest, but invite you back in a few months to talk about process-based readiness, because we can talk about people being ready and teams being ready, but is our process ready? How do we even know if it's ready? Is our facility ready? How do we know if it's ready? Do we take those things for granted, and it can seem very imposing to try to make those things better. So would love to talk to you about that in the future.
That sounds fun.
All right. Thanks, Catherine. Have a great rest of your day. Thank you, James. And thanks to everybody. James, what do we need to say to our listeners at the end here?
Let us know what you thought on LinkedIn, YouTube, or email daretobeready@harvardmedsim.org.
Thanks, James. Thanks, everybody. Thanks,
Thanks
Catherine.
so much to both of you for having me today. I enjoyed the conversation.
Likewise.